Good morning, everyone. My name is Nicole Scudder, and welcome to the Resident Series. Today's lecture is going to be Digital Dentures in Your Practice, and this lecture is being presented by Tremaine Watkins, CDT. And now it is my pleasure to introduce Adam Dreyfus, Director of University Government Institution. Adam is all yours.
Thank you so much, Nicole. Good morning to everybody. Before we get into this, I personally just want to say thank you to all of you for your continued support of this program and your partnership with NDX National Dentex Laboratories. Myself, Bianca, and Heather, it is our honor and our privilege to support you through your educational journey, and we look forward to continuing that partnership today, tomorrow, and for the future. So without further ado, I want to turn it over to our esteemed speaker, and like I like to describe him, one of our encyclopedias of knowledge. Tremaine Watkins, take it away.
Good morning, everyone. Thank you very much for joining. I got a couple housekeeping slides to do, and then let's jump into the presentation. I am a full-time employee of National Dentex Corporation, so I've been paid to do this presentation, but other than that, there's no commercial support for this, so any products or anything that I mention are things that I believe will be helpful for you guys. So let's talk about dentures in general. And at the stage that you're at, I know you guys are providing treatment for edentulous patients, but in a lot of private practices, it's something that maybe we could do a little bit more with, especially because so many people are dissatisfied with their dentures. I kind of put this slide in to help people understand the opportunity that's there, but it's also a group of people who could be receiving better treatment. So we'll be talking about how we can deliver that better treatment today. And then if you look at 81% dissatisfaction, I kind of put this in just to see, kind of compared to what we're doing in dentistry. In dentistry, we're doing 2.3 million single implant crowns. So something that a lot of people are interested in. And on the other hand, there's 40 million arches of dentures that are that could be treated. So there's a good patient care responsibility opportunity and a good financial opportunity as well. So let's talk about, today we're going to talk about digital dentures and how this makes it quite a bit more predictable for you and can make this a better part of your practice. As you guys know, two different ways to talk about jaw relationship. Occlusion would be the way that the jaws meet in when we're swallowing or when our teeth are interdigitating, whereas articulation we're going to talk about is the way that we move our jaw when we're doing chewing. One of the things we want to keep in mind with dentures is that, as you guys know, denture patients and dentate patients chew differently. Dentate patients tend to chew in a warped teardrop, where denture patients tend to slide side to side, which affects our stability of our denture. A lot of times you'll see patients and they'll say, oh, my denture doesn't fit. It doesn't have any retention. But one of the things we want to keep in mind is because of all that's really holding a denture, unless we use, attachments, is the suction. And so it's not that strong. If we have occlusal interferences, it's going to cause a problem and kind of overwhelm the retention that we have. So we really, as we're talking about making a stable denture, occlusion becomes really important. Historically, when I got going in this field, bilateral balanced occlusion was the thing. Everyone said, oh, this is what we want to do. This is the most important thing, et cetera, et cetera. And it does work really well. The idea is that you use teeth with similar cusp forms. And as the person moves in function, this cusp, the balancing cusp ride, what we've found in reality is that it's very difficult to create this occlusion. It's difficult to create it in the laboratory, but it's even more difficult to get it to work in the mouth, especially if we're not doing face bar articulations and different things like that. So what's been found is that lingualized occlusion gets a more predictable occlusion. And the difference, as you can see, is the cusp angle of the mandibular tooth. So instead of having equal cusps, we tend to have a flat tooth, say a 10 degree on the lower, you have a 22 degree on the upper, and the upper teeth are set so that this cusp doesn't interfere. It gives a mortar and pestle chewing. A lot of times when this was first talked about a long time ago, people were concerned that patients wouldn't get as effective chewing. But what's been found is that measured chewing is when both of these are well executed. Measured chewing force is very similar, but with this, patients tend to feel more stable. We're going to talk a little bit about tooth position. I know a lot of times us laboratories set the teeth, but you guys want to be able to provide good guidance for your laboratory so we can get good results the first time. And these rules apply for both digital and analog dentures. So as you guys know, we want to make sure that when we're setting the anterior teeth, of course, aesthetics are primary. We want to keep in mind that, again, aesthetics aren't the only thing with dentures, because if we set the teeth too far off the ridge, we're going to wind up creating an anterior lever that will again break the denture loose and prevent the stable fit that we want. We want to, most of the time, patients like 1 to 2 millimeters of incisal edge display with the lips parted and at rest. And most patients don't like to see a lot of gum. So the high smile marking is going to be really important. We want our lower incisors generally aligned with the lower lip. And then, of course, our dental midline and our facial midline parallel. As you're working with more patients, you'll realize that this is a little more challenging than it sounds. Incisal angle parallel to the interpupillary line. And then in general, if you don't have an existing denture, you're trying to figure out where to put the labial surfaces of the maxillary centrals. Usually 8 to 10 millimeters from the center of the incisive papilla is a good starting point. One of the things that gives us a little bit of flexibility in where we put our anterior teeth is that in centric, we want to have slight disclusion between the upper and lower teeth. But as the person starts articulating, we want to create even occlusion again, so we have balance forces that aren't tipping the denture. A lot of times what we'll talk about is that we want the vertical and horizontal overlap on our dentures to be the same. So if this is 2 millimeters, we want this to be 2 millimeters. It'll help with more stable occlusion. Posterior teeth. These, we need to be careful not to set these for aesthetics. If the person's class 3, we got to set the teeth class 3 because of the additional forces in the posterior region. The more cantilever we set, the less stable our dentures are going to be. So we really need them set over the ridge. One of the things we want to keep in mind is that we set the anterior aspect of the occlusal plane is set by the incisal edges of the maxillary central teeth, but the distal aspect is set by the retromolar pad. We generally bring the plane of occlusion halfway up the retromolar pad. And so when you're doing your scans or your impressions, you want to make sure you capture that so your laboratory can set your teeth in the proper position. And then this is probably a good thing for us labs to keep in mind, and you guys as well. For an average person to get the good tongue space that they need, we want to make sure that our lingual cusps of our posterior teeth don't intrude beyond the mylohyoid ridge. As we're setting our teeth, we really don't want to come up the ramus with our mandibular second molar, so sometimes that means we need to leave them out. We want to stay off the tuberosity on the maxilla, but it's more important to try to get 4 teeth on the maxilla because we really want to support the drape of the cheek so that we don't get cheek biting for our patients. And then by balanced occlusion, what I mean by this is that we want even occlusion. we're better off using lingualized occlusion, but when our patients fight together, we want to make sure that we have even centric contact, even movement. And then if we have that and we have the teeth set over the ridge, occlusal force is doing the best it can, so to speak, to keep our denture stable. With really, in general, the more ridge anatomy, the more tooth anatomy you can get away with. So if you have a really flat ridge, it's going to be difficult to make the case stable. So you'll definitely want to have a conversation about overdentures with your patient. But in general, flatter ridges you're going to want flatter teeth. As you guys know, one of the keys to stability is making the dentures as large as we possibly can without contacting mobile tissue that's going to lead to sore spots and the like. So when you're taking your impressions, it's really important to capture all that for your laboratory. So you need to capture the tuberosities, the hamular notch, the vibrating line, the vestibule. When you do border molding, it's really, really helpful with the vestibular information, because that way, when we design the denture, we can design it exactly the way you captured the border molding, and it'll make it more predictable. In the mandible, we talked about we need to get the retromolar pad. We need to see the mylohyoid ridge, but we also want to make sure we capture the external oblique ridge, because this is a nice, as you know, there's a lot of occlusal force here, and getting a broader base here will make the denture more stable and will also help with potentially with limiting resorption over time. So let's go through the analog process really quick. Boy, that's a weird picture, but I don't want to spend too much time on this. I just want to, revisit it so we're all familiar, because I'll be relating the digital workflow to this. So if you're doing a standard process, of course, you do preoperative impressions to make your custom tray. They don't need to be perfect. They can be done in a stock tray, but the more accurate they are, the better your custom tray. Your second appointment would be your custom tray appointment, and I'd recommend that if at all possible, you want to do border molding. So again, that way your denture can be a copy of the impression, and you'll be less likely to have sore spots, excuse me, and different things like that. Third appointment, your bite block. One of the things, this can be one of the really overlooked things in dentistry. So many times we think of this as, okay, the point of this is to get the CR at the correct VDO. But this is kind of like a try-in in miniature. If you set this edge exactly where the maxillary incisal edges should go, if you shape this so that the buccal corridor is correct, mark the midline, mark the edges of the nose for the cuspid eminences, especially mark this high lip line. What you'll find is that your setups, and be it analog or digital, will be more predictable. So your fourth appointment, be your wax try-in. You guys have all seen this before. One thing I would say about this is if you're doing wax try-in still, make sure you take a bite over the wax try-in every time. Patients seem to bite better on teeth than on bite blocks. So it gives us an opportunity to fine-tune the case before we do the delivery, and then you get to your fifth appointment, your delivery appointment. So let's talk about digital. I remember when digital dentures first came out, they seemed like a gimmick to me, honestly. But as I've become more familiar with them, as the materials have advanced, it really can make a big difference in your practice. One of the things, of course, you have to think about is dollars per minute, and if you can make money doing these things. And the problem with 545-minute appointments is that a lot of times it's just not financially practical to do these. And especially when you start adding additional try-ins and post-delivery adjustments. I use the angry person icon on purpose, because sometimes, especially if there's problems with the case and or poor communication about what it's like to actually wear a denture or what we can achieve with a given person's ridge morphology and the like, it can be a source of real frustration. And then, of course, there's problems that are kind of unique to the analog process. One is tooth delamination. When we're processing dentures, as you guys know, the final teeth are in the wax up. And wax is a great separating agent for acrylic. So when we're doing our processing, we work really hard to clean all that wax off. But sometimes if there's a little bit left, it can allow a single tooth to come out. Breakage, of course, can happen for dentures. And one thing is that when we're waxing them in the laboratory, we use a defined amount of wax to define the base plate, but then we'll kind of make it look pretty and smooth it out and stuff. So sometimes we don't know exactly how thin it can be in a given area that can lead to fracture. And then lost dentures. You know how hard it is sometimes to get a denture made and you're like, all right, I got something good, patient's comfortable, things adjusted, and then it gets lost. And you're like, holy smokes, I have to start all over again. That's not necessarily the case with digital. And so we'll talk about that in a minute. So with the digital workflow, we get a better fit. As you guys know, and I've been talking about this too, we talk about suction, but in reality, what it is very tight adaptation of the denture base to the patient's mouth. Now, we all do things to try and compensate, but at the end of the day, traditional acrylic has an 8% shrinkage. And so we do things like post-dams and injection to try to compensate for it. But what happens is that even when the process is done really, really well, we sometimes don't get the kind of adaptation we need to have a really successful denture. So on the bottom right here, the green areas are the areas in an in vitro study where the denture is perfectly adapted to the tissue. So you can see that obviously you have the post-dam here and the crest of the ridge. There is some good adaptation, but with a printed denture, because the thing is built up in 100 micron layers, you have very, very accurate fit. One of the things you'll need to decide with your digital dentures is if you want a post-dam or not. Oftentimes we choose not to have a post-dam because it can lift the digital denture and defeat some of the purpose of doing the digital denture in the first place. Again, it's good to keep in mind that a post-dam is created primarily to compensate for polymerization shrinkage. When you don't have polymerization shrinkage, then you don't have to worry about that. When most dentures, at least the dentures that we're doing and most of the ones that I've seen, right now we're doing printed teeth and printed base, which seems to be where the industry is right now. The printed materials, we'll talk about it in a minute, have moved quite a bit. And so we have some great materials. And so they do need to be bonded together. But there's two things that make it more sturdy compared to the analog process. One is that the teeth are either one big set or maybe three sets, posteriors and both posterior sets and anterior. So they're not they look like individual teeth, but they're not individual teeth that can break out. Secondly, there's a bonding procedure that we do when we're doing the post-curing of a digital denture so that it's not held by mechanical retention. It's held by chemical retention, similar to how you guys do composite bonding to a tooth. The newest materials, especially like using Lucitone digital print as an example, actually are stronger than injected resins. And that's a change. The first generation of digital denture materials oftentimes were a little bit more porous and a little bit less sturdy than traditionally made or analog dentures. So some people have had some bad experiences with those, but the current crop of products are much stronger. So you're actually getting a better, a sturdier denture for your patient, in addition to the predictability of digital manufacturing in terms of base thickness and the like. You can preserve your denture files. So when you get your digital denture, ask your laboratory to give you the files for the base and the teeth, and you can save it in the patient's digital chart. And then if there is a If it gets lost or broken or whatever, you can send the files over for reprinting. And then the last one is trying to think of a good one word to explain that, but oh, my apologies, is continuity. When you go from a try-in to a process denture, the case has to be invested, boiled out, processed, divested. There's a lot of high force and heat and different things like that. There's more possibilities for teeth to move. That's why sometimes I know it can be frustrating when you have an awesome try-in and then you get your delivery and you're like, why is it not the same? And also with analog process, the try-in fits similar to the final, but not exactly the same. With the digital process, the try-in will fit exactly the same as the final. So you can, at the try-in appointment, you can make a judgment as to, does this case have the retention and stability I need, or do we need to do something else? Also, with what I mean by continuity is that the tooth position is set digitally. So if you do the try-in, you're like, this is perfect, then the final denture just is basically turned into two pieces, separated into two pieces digitally. The two pieces are printed and then they're bonded together. If you want to make changes, it's not heat up the wax and move it around. It's grab the tooth in the software and move it a millimeter or 3/4 of a millimeter or rotate it or whatever. So, and I've talked to a couple dentists who have switched to digital dentures, and the fit basically and the continuity are the two things that are so much more advantageous. So you're like, well, what if I don't have an iOS, or I don't want to get one, or my iOS doesn't scan tissue very well, or whatever? What about me? Can I do a digital workflow? And the answer is yes. You'll be limited by, in both cases, you're still taking an impression, so you need to take a really nice border molded impression to get a really good result. So we're going to talk about analog records to a digital denture and why that's different than analog to an analog denture. We'll talk about digital records to a digital denture, and then I'll show you facial scanning, which I think is super cool. I think it's where we're headed, and I'll kind of talk about why it's advantageous to dental laboratories, because it might not be as evident from a clinical perspective, but I don't want to get ahead of myself. So let's say that you want to do an analog impression, you want to go to a digital denture. Your first couple appointments will be the same. So you could take a preliminary impression, have your custom tray made, and then make your border molded custom tray and send it to your laboratory. So your third appointment would also be, I'm going to leave the mush bite thing out. I think it makes it confusing. So it'd be your second appointment if you did your impression in a stock tray, or your third appointment with custom tray, you do your bite rem. You're like, okay, well, what's the difference? So here's the difference, is your try-in appointment. So when you go to your try-in appointment, it'll be very, very different than an analog denture. What you're going to get is what we call a monoblock or a monolithic denture, where the whole thing is printed out of tooth-colored resin. So the intaglio surface, again, will fit exactly the same as the final will. You'll have the teeth in the positions that we talked about. But this is something that you can adjust. So I like this picture. I don't remember where I found it, but it shows all the things you can do. See how the clinician has marked where the midline need to be changed, like this needs to be shortened, bulk this out, rotate this. So you can make some nice marks. You can adjust the occlusion, and again, your laboratory will be able to scan this, and because this is, I'm assuming that you don't have a scanner, and so we're talking about an analog workflow. So you'd send this back to your laboratory. The other thing you want to keep in mind is that your patient can do a test drive with this. So obviously you wouldn't send a patient home with a wax up because they can't chew with it or whatever. But with this, they could actually wear this for a few days. So this can be a good way to check border lengths and comfort, occlusion, stability, all those things. Make sure that if you're doing this workflow that you, again, take a bite over this, and you want to take a nice series of photos with this in place so that your lab can see changes that you want to make. And if your lab sees little subtle things that make it a little bit prettier, they may tune it up a little bit as well. So you want to do lips parted to show the incisal edge, high smile, and it's good to do both those views frontally and in profile. If you're making small changes, it can be made like with an analog denture between this and the final. And again, it's more predictable because if you ask for a millimeter, you get a millimeter. But if you want to do large changes, it's worthwhile to do another try-in because you want to make sure our goal is to have a perfect try-in and duplicate it with the printed denture. And so then, again, your laboratory will turn it into two pieces, basically, or actually will undo the process that merged them into one piece to make the try-in, is what really happens in the software if you are interested in that. And then print the components, bond it together, finish it all up for you. And then you're ready for delivery. So you'll need to go through your standard delivery process. But one of the things you want to, I've talked to, I don't know if very many of you know Dr. Wagner. Dr. Wagner is out here in Albuquerque, where I live, and was one of the pioneers of digital dentures. Prosthodontist deals with cases that are very difficult. He said he can't remember the last time he did a post-delivery adjustment with a digital denture. And again, he's been doing it for a long time and has a lot of experience, but he was never able to get to that point with his analog dentures. So you really can make, now I'm talking about the process up to delivery, but I know that post-delivery is a huge source of frustration sometimes with analog dentures, and you can make that much less of a headache for yourself as well. So let's say you have an iOS and the person does not have an existing denture. So it's important to keep in mind that the reference denture workflow that I'm going to show last is the gold standard for digital dentures. So if at all possible, you need to get your patient to bring in their denture. 80% of people have some denture, and the trick is convincing them, yes, I know you don't like the tooth position. Yes, I know it doesn't fit very well. I can address all that. I just need something to use as a custom tray. But you can also take a tissue scan. One thing to keep in mind is that because of the size of the wand, most intraoral scanners are going to distend the cheeks a little bit. So you might wind up raising the vestibular border. So you want to kind of keep an eye on that. Also, dry the field really well. Kelly Bevington is the head of our intraoral scanning team, and she's often points out on these 2x2s, your friend, have a lot of them handy. So Dr. LaRussa in Italy developed this scan flow, and it's been found to be pretty effective. So you always want to start by indexing to the ridge and then scan the palate kind of back and forth and then scan the vestibule. You need to be able to overlap so your scanner can pick up the tissue. Sometimes you'll need to turn off AI trimming. It's going to depend on your system. Some of the newer ones have a removable setting, which can be so helpful for this. So you'll create your scan, and then at your next appointment, you'll do a bite block, then you'll do your printed try-in, and then you'll do your delivery. So you're still doing a 4 appointment, and the reason is the bite block. So let's talk about how we do a 3-appointment digital denture. So this is reference denture workflow, again, means that the patient has an existing denture. So you'll start out by evaluating the borders. Do yourself a favor and don't adjust the patient's existing denture, because as a lot of people tell you, they're like, oh, you adjusted my denture, I want the new one for free. So you got to be careful about that. Not everybody does stuff like that, but protect yourself. If there are, like this case where the denture is very, very short, you may need to use compound or something like that to build up the borders. Otherwise, you want to paint the intaglio surface with adhesive and then use a heavy body material and do your border molding. Once that's set, use a light body material and go through the border molding movements again. When you're done with border molding on the maxilla, the case should have suction. And on the mandible, if you try to dislodge the anterior teeth, assuming there's some retentive anatomy, it should be difficult to do. Don't forget that even with digital dentures, we're not going to be able to add retention. So however much retention there is on your master impression, that's the most you're going to have. This may seem counterintuitive, but you want to take your photos after you've done your impression. The reason is that now the denture is stable. So go ahead and take the photos we talked about: low lip, high smile, profile, and frontal. More photos, the merrier, because then we can see more about your patient. It's interesting with this person, it's a good example of it might be worthwhile to open her bite a little bit because you can see that her chin's a little bit protruded there. So then, you take a bite and then trim the bite so that, like, this could be trimmed a little bit more so you can see the teeth. So you have the relined upper denture, in this case, relined lower denture to bite. You're ready to do your scanning. You'll scan the dentures extraorally, and you'll start, let's say, on the upper by scanning in the center of the palate, go around and around in circles until you get out to the external surface. Scan over try to pick up the cameo surface while you're scanning. Then start scanning the cameo with an area that you've already picked up and build vertically like this, up and over. Keep in mind that if you miss an area, it's better to come back and pick it up than to keep scanning and scanning and scanning in one area, because it makes the file very large and can confuse the stitching software that's so important. Then scan from the occlusal into the palatal area, circles going down. On the mandible, again, you want to start on the intaglio surface. And what you want to do with the intaglio on the mandible is go back and forth like this, so that you're picking up, again, some of the cameo surface. For any of you that have done a scan of a denture before, you know the trickiest part is going from the inside, so to speak, to the outside. So if you set up your internal scan so that you're already picking up some of the external surface of the denture, it'll really help you out. And then you can scan the labial surface up to the occlusion, same thing, then the lingual surface. It's best to put the dentures back in the mouth and take the bite scan with your bite in place. Keep in mind that you should do from the first molar to the cuspid on both sides. Taking the extra time to scan a larger area on both sides will make your bites more accurate. And this is the case for anything, not just dentures. It's something we see a lot in the laboratory that could be a little bit better. So then, once you finish that, you'll want to strip the impression material out of the denture. You can use a little bit of isopropyl alcohol to remove any adhesive, and then dismiss the patient, turn in your scans and your prescription. So in the laboratory, we'll get going on designing your denture. And so I put this in because I thought you might find it interesting. So the purple is the person's existing denture, and then the white teeth, this is 3Shape. We can either use 3Shape or exocad to design it, are the new teeth. So we can set the teeth using either a bite block. The purple would be a bite block if it were bite block, otherwise the existing denture. And then we'll make the monoblock try-in for the second appointment and then the delivery for the third appointment. So this gives you a 3-appointment denture that you can do predictably. Let's talk a little bit about facial scanning. So facial scanning is different than doing exocad smile aligner, where you align a 2D photo to your 3D scans. That can be helpful, but a facial scanner takes an STL of the person's whole face. And you're like, well, who cares? I can see the person's face. True. And that's one of the main differences between working in the clinic and working in the laboratory is we can't see the patient's face. And if you think about it, a lot of the records that you do clinically are to represent the patient's face. So in other words, if you take a study model, what the study model shows is it shows teeth that look pretty good in the person's face and had appropriate support. When you do the bite block, it shows how the lips and cheeks need to be supported, where the plane of occlusion is, all that stuff. When you take a 3D scan, we actually align your iOS scans to that, and then we can see the person's face just like you can. Now, these are all frontal views because they look cool, but when you're actually doing design with the 3D, you can turn it and look from the chin side and say, oh, that lip support could be a little bit better. Or you can look at, of course, buccal corridor. You can look at the profile view. There's just a lot of neat things you can see, and it allows your laboratory, once we get used to having the information, to actually see exactly what you're seeing. With good facial scanning systems, it becomes very, very predictable. And I've seen a bunch of these delivered, so it's kind of funny. This particular case, I saw this one, and what we did is when the case was delivered, it was an all-on-X case, we turned the design file so that it was turned the same way as the person was sitting in the chair, and it looked exactly the same. So once you get this process going and you really feel confident about it, your second appointment is a virtual appointment. You can look at it yourself. You can show it to the patient. There's a thing called exocad web viewer that lets you put all this together, and you wouldn't actually print the try-in. You'd look at it and say it looks good, and then your second appointment would actually be your delivery. So I get that this is maybe a little high tech, but I hear that there's a new upgrade coming for iPhones that may allow facial scanning with just your iPhone. So I think especially if that comes to be, we're going to start seeing a lot more of this. And just keep in mind that the goal of facial scanning is to allow your laboratory to see exactly what you see, so that you don't get those frustrations of, well, it looks good on the model, but it doesn't look good in the mouth. This is the solution to that. Printing or milling. So there are a couple of denture workflows that still do, like the Ivotion, for instance, that still do milling. And milling is a very, very accurate process. Really, the only limitation is even with 5-axis mills, there's a limit to how much undercut we can mill out. So sometimes in the maxillary anterior, that can be a problem. Also, nesting it, getting the teeth, the transition between the pink and the white in the right spot is a problem. At scale, the problem is that it's really, really hard on the equipment. Ironically, because we mill zirconian green state, PMMA is much harder on spindles and different things like that. And it takes a long time. It takes 3 or 4 hours to mill a denture. So most everybody has moved to printing. Like I said, some of the earlier print materials weren't that great, and so the printed materials got kind of a bad reputation. But with Lucitone digital print and then some of the other materials that have come out since then, we now have the ability to print very hard, very durable teeth and very strong, high-impact bases to get a good result for you. So from a theoretic perspective, printing is better, because the point of milling is you take something that's too big and turn it into what you need, generating a lot of waste. With printing, you take a vat of uncured resin and you only cure what you need, so it's intrinsically less wasteful. There's a certain, the time in printing has to do with how tall the thing is, but you can print a lot of items at the same time, which can be helpful. And it's every time you run the print, it's the same amount of wear and tear on the equipment, so it tends to help the equipment last longer, which is good as well. So what are some other workflows that we can do with digital dentures? There is a copy denture workflow, if you're aware of it. Now, depending on which software your laboratory is using, it won't be quite as close as a CEREC biocopy, but it'll be very, very similar. And you can do a reference denture workflow. If the patient likes everything else and the denture just isn't fitting very well, if you do your border molded reline impression and do a reference denture workflow, then your lab can replicate the teeth and replicate the majority of the pink design and basically add to the intaglio. Immediate dentures, another good workflow for digital dentures. In this case, it's not that much different than scanning for a crown and bridge case. You just have to remember that you need a much bigger scan. So you need to scan beyond just the tissue that you pick up doing a crown and bridge scan. You need to deliberately scan the vestibule, scan into the hamular notch, scan the whole palate. It's okay to use I would start with the teeth because it's going to give you a better reference for your scan, but then you want to make sure that you pick up everything that's necessary for denture. As you can see in this case, it's only a maxillary denture. So the mandible is kind of a crown and bridge scan, and the maxilla is kind of a denture scan. Talk to your laboratory about what you want in terms of sculpting of the bone or what you're planning on doing. In general, when we're extracting in the lab, we do what I call a lab extraction, which is basically digitally cut where the tooth comes out of the gingiva. So as you know, when you do an actual extraction, that'll have the effect of leaving a little bit of space in the prosthetic, which is usually good. If I were you guys, I'd sooner add a soft reline material than try and fit an immediate denture to place. But if you are planning on doing bone sculpturing and want a little more pressure, ask your laboratory. And again, it's a digital process. You could ask your laboratory to send the file of the after extraction and the before extraction aligned to each other, and then you can kind of turn one off and look at it and see, oh, I'd like a little bit more here or there. So you can get a little better communication with that. And printed over dentures. As you guys know, over dentures have become the standard of care, certainly for the mandible. And so I'm sure you'll be doing more and more of those. This is showing a locator scan body, which will allow you to do a direct pickup of the male housings. But yeah, with the increased strength of the digital dentures and the predictability, it can make your overdentures go a little bit better as well. Obviously, I don't have enough time to go through this whole thing today, but keep in mind that that this is a workflow. For digital, let me add one other thing. There's basically two ways you can do a digital overdenture. One is measure, place locator abutments, use this locator scan body, and then you will lute the attachments into the printed denture at the end of the process. The other is to use normal scan bodies and a reference denture workflow. And with that, then your laboratory can purchase the locator abutments for you in the correct heights and then send them to you. And if you want, with that workflow, you can actually have your laboratory process the males into the try-in. There'll be a little bit of an additional fee because you'll need 2 sets of males, but it would allow you to do a full test drive try-in with the monolithic denture, which could be very helpful, especially if your patient's very concerned about borders. That way, when you do the try-in, you can do the try-in with the borders adjusted. Some of our laboratories are specializing in these overdenture workflows. So keep that in mind. Well, that's it. That's all I have today. So thank you very much to everybody for joining in it.